Okay, so let's talk about dizziness. I mean, it's something almost everyone feels at some point, right?
That feeling.
That kind of fleeting, lightheaded moment, maybe feeling a bit off balance. But what if it's more? Like, what if it's this persistent, really disorienting feeling that actually gets in the way of your daily life?
That's a great starting point, yeah. Because what's truly fascinating, I think, is how often dizziness or spinning sensations, that feeling of imbalance, how often it traces back to a specific system, one that's often, overlooked.
Oh, which is?
The vestibular system.
Right.
So today we're doing a deep dive into the sources, really trying to untangle the complexities of dizziness, vertigo, and all sorts of balance disorders.
Okay, good. So we'll explore how these different types of dizziness show up.
Exactly.
And where they come from, which can be surprising sometimes.
Definitely.
And most importantly, what can actually be done about them. So everything from like simple exercises you might do at home,
Right.
all the way to more advanced therapies.
They cover the range.
Yeah, sounds like we might have some real aha moments for people listening.
Hopefully.
So first off, let's clarify some terms, because your sources make a really important distinction here. We tend to use dizziness and vertigo almost like they're the same thing.
People do, yeah. Very common.
But they're not quite the same, are they?
Not exactly. Dizziness is more that general kind of woozy or disoriented feeling.
Yeah.
Feeling lightheaded, maybe unsteady on your feet.
Okay, the general unsteadiness.
Right. Whereas vertigo is much more specific. It's that distinct sensation that you're spinning, or maybe the room is spinning around you.
Ah, that specific spinning feeling.
Yeah, it's a sense of motion when there isn't actually any motion. A false sensation.
Okay, that makes sense. So, with that distinction clear, what exactly is this vestibular system you mentioned? Why is it so crucial for balance?
Well, the vestibular system is this incredibly intricate network. Think of it like your body's internal gyroscope, or GPS. It's mainly located deep within your inner ear.
In your ear, okay.
And it's made up of these tiny fluid-filled tubes, the semicircular canals, and also these small sacs called otolith organs. Now, these structures are constantly reacting to how you move your head and also to gravity. And they send these vital signals straight to your brain. But it doesn't work in isolation. It works really closely with your vision, what you see, and also proprioception.
Proprioception? What's that again?
That's your body's kind of subconscious sense of where its parts are. Like where your hand is without looking.
Ah, right. That sense.
So vision, proprioception, and the vestibular system all work together, constantly feeding info to the brain to maintain your balance in real time. When those signals get mixed up or disrupted, well, that's exactly when you feel off. Dizzy, unbalanced, vertigo.
It really sounds like a delicate balancing act, literally. And your sources highlight that when things go wrong, the problems usually fall into two main buckets, right? Depending on where the issue starts.
Exactly. And understanding this difference is key because it guides the diagnosis and treatment. So first, you have peripheral vestibular disorders, or PVDs.
Peripheral.
Meaning they affect the inner ear structures themselves or the vestibular nerve. That's the nerve carrying the balance signals from the ear to the brain. And these are by far the most common types of balance problems people experience.
Okay, most common. And the second type?
That would be central vestibular disorders, or CVDs. These affect the parts of your brain that are responsible for processing those balance signals coming from the inner ear. So the problem's in the central nervous system.
Got it. Peripheral is the ear or nerve, central is the brain processing it.
Precisely. And generally, the symptoms people report, regardless of type, often include that overall dizziness, feeling off balance. Sometimes a sensation of floating, or that spinning we talked about, vertigo. Blurred vision is common too, disorientation.
Falling, maybe?
Definitely falling or stumbling. And then sometimes, and maybe less common, but still important, are things like nausea, vomiting, and even anxiety can come along with it.
Okay, now that we sort of have the framework, let's dive into some of the specific conditions, the ones people might actually encounter. What stands out from the sources as, the frequent flyers, especially those linked to the inner ear, the peripheral ones?
Well, one of the most common culprits for acute vertigo, meaning it comes on suddenly and severely, is vestibular neuronitis. The sources suggest it's actually surprisingly common. It affects quite a few people.
Neuronitis sounds like nerve inflammation.
Exactly. It's widely believed to happen when a herpes simplex virus like the cold sore virus gets reactivated. But instead of a cold sore, it affects the vestibular nerve, or the ganglion, those nerve cells involved in balance.
Wow. Okay.
And the key thing here is you get this really intense vertigo, lasts for several days usually, but And this is important. It happens without affecting your hearing or causing other neurological symptoms.
Just the balance nerve is hit.
Right. People are typically very unwell during this time, really struggle with just daily activities. Now, treatment-wise, doctors might briefly use anti-nausea meds, but the sources emphasize stopping those quickly.
Why stop them?
To let the brain's own natural compensation mechanisms kick in, your brain needs to adapt to the change, and early vestibular rehab exercises are also really important.
Makes sense. Let the brain figure it out. That sounds pretty rough. But then there's the one we hear about a lot, benign paroxysmal positional vertigo. BPPV. That's a mouthful.
It is a mouthful. But BPPV is incredibly common, actually the second most common cause of vertigo overall. And what's fascinating, truly, is how relatively simple the underlying mechanism often is.
Simple. How so?
Yeah.
It feels anything but simple when it happens.
I bet. But the typical symptom is this brief, often intense, spinning feeling, vertigo, that happens specifically when you change your head position relative to gravity.
Like rolling over in bed or tilting your head back.
Exactly. Lying down, sitting up, looking up at a high shelf, those kinds of movements. And the aha moment here is understanding the cause. Usually it's these tiny calcium carbonate crystals. Siliconia, they're called.
Crystals in my ear.
Yep. They're supposed to be stuck in one part of the inner ear, the otolith organs. But sometimes they break loose. Could be due to age, a head injury, even sometimes for no known reason. That's called idiopathic.
Okay, so these crystals break loose. Then what?
Then they float into one of those fluid-filled semicircular canals we talked about. The canals that sense head rotation. So now you've got these tiny rocks rolling around in a system designed to detect fluid movement.
Ah, like pebbles in the works.
Precisely. It sends confusing, incorrect signals to your brain about head movement, especially when gravity makes the move, like when you lie down.
Yeah.
Causes that sudden spin.
Okay, that makes a weird kind of sense. So if it's these loose crystals, how do you fix it? What should people know if they suspect they have BPPV? This seems crucial.
This is where there's a really important insight for listeners. The American Academy of Neurology, based on strong evidence, strongly recommends diagnosing BPPV using a specific test done in the office, the Dix-Hallpike maneuver, and then treating it with something called a canalith repositioning procedure. The most famous one is the Epley maneuver.
The Epley maneuver, I've heard of that. It's like a series of head movements.
Exactly. It's a specific sequence of head and body positions designed to use gravity to guide those loose crystals out of the canal and back into the part of the inner ear where they belong and won't cause trouble.
Does it work?
Very often, yes. And here's the really key detail from the sources. Things like expensive MRI scans, complex vestibular testing, or medications like antihistamines or benzodiazepines are generally not recommended for typical BPPV.
Really? So no need for long-term meds?
Usually not for the BPPV itself. Most cases can be effectively treated right there in the doctor's office, often in just 1 or 2 sessions with a maneuver. No need for prolonged physical therapy usually. It can be a remarkably quick fix.
That's genuinely amazing. Such a disruptive condition, potentially fixed with a simple maneuver. Huge takeaway there. Okay, what about Meniere disease? Another inner ear condition people hear about. How's that different?
Meniere's is quite different, yes. It's a chronic disorder of the inner ear. It's typically characterized by what they call a classic triad of symptoms.
A triad.
Yep. First, episodic vertigo, unpredictable attacks of spinning. Second, tinnitus, which is ringing or buzzing in the ears. And third, fluctuating hearing loss. People often also report a feeling of fullness or pressure in the affected ear, like it's blocked.
That sounds miserable. And it's chronic.
It is. And if it's left untreated, the sources say severe hearing loss and a permanent weakness of the balance system on that side are pretty much inevitable. But a quarter of patients eventually develop it in both ears.
Wow. What causes it? Is it crystals again?
No, not crystals this time.
Yeah.
The underlying issue seems to be a problem with fluid regulation within the inner ear. It leads to something called endolymphatic hydrops. Basically, too much fluid builds up, creating excess pressure inside the delicate inner ear structures.
Eye drops. Like water pressure.
Kind of, yeah. Too much inner ear fluid pressure. Thankfully, most patients respond well to conservative treatments. Things like seriously restricting salt intake, using diuretics or water pills to reduce overall body fluid.
Managing the fluid.
Exactly. Sometimes corticosteroids can help calm things down during active phases. For severe, disabling vertigo that doesn't respond, there are other options like injections into the ear or even surgery, though surgery remains somewhat controversial.
Okay, so managing fluid is key for Meniere's. And then you also mentioned labyrinthitis and vestibular neuritis earlier. You said they were similar.
Very similar and often confused. Both are types of inner ear inflammation, often caused by viruses like from a cold or flu. Both cause dizziness or vertigo, unsteadiness, feeling sick, and often they get better on their own within a few weeks.
So what is the difference then?
The key difference lies in what part of the inner ear is inflamed. Labyrinthitis involves inflammation of the labyrinth itself, that whole maze of canals and organs. Because it affects the whole labyrinth, it causes both balance problems and hearing loss, often with tinnitus as well.
Okay, labyrinthitis affects hearing too.
Right, but vestibular neuritis, which we talked about earlier, is inflammation of only the vestibular nerve, the balance nerve. So with vestibular neuritis, you get the intense vertigo and balance issues, but no hearing loss or tinnitus. That's the crucial distinction.
Okay. That clarifies it. Neuritis is just the nerve, labyrinthitis is the whole structure, including hearing parts.
Exactly. And because they're usually viral, antibiotics typically don't help unless a secondary bacterial infection is suspected. Short-term relief from things like motion sickness meds might be okay for a day or two, but again, stopping them allows the brain to compensate faster.
So it seems like the inner ear is ground zero for a lot of these issues.
It really is. The peripheral causes are very common.
But your sources also point out that dizziness isn't always an ear problem, right? It can be a symptom of things happening elsewhere, maybe even in the brain.
Absolutely. This is really important, and not all dizziness starts in the ear.
So what else should people be aware of? Maybe some surprising causes.
Well, one very common one is actually migraine, specifically vestibular migraine.
Migraine causing dizziness, not just headache.
Yes, it's a common disorder affecting maybe 10% of men, up to 30% of women, according to some sources, and about a quarter of people who get migraines also experience motion intolerance or motion sickness. But the key thing with vestibular migraine is that you can get vestibular symptoms like vertigo, dizziness triggered by head motion, nausea, without necessarily having a headache at the same time.
Wow, so a silent migraine, but with dizziness.
Exactly. It can have before, during, after, or completely separate from any headache phase. Treatment is often similar to regular migraine management, identifying and avoiding triggers like poor sleep, certain foods, stress, and using preventative or abortive medications if needed.
That's fascinating. A good reminder that symptoms can be tricky. What about more serious things like stroke?
Yes, unfortunately, dizziness can sometimes be a warning sign. Transient ischemic attacks, TIAs, sometimes called mini-strokes, can present with dizziness as a key neurological symptom. These are sudden episodes that usually resolve within 24 hours.
Okay.
And actual strokes, especially those affecting the blood supply to the back of the brain, the vertebrobasilar system, that area supplies the brainstem, the cerebellum, and parts of the inner ear. So a stroke there can definitely cause acute vertigo.
Is there a way to tell the difference quickly, say, between that and vestibular neuritis?
It can be difficult, but one potential clue doctors look for is walking ability. Patients having certain types of strokes, like in the cerebellum, are often completely unable to walk without support during the acute phase. That severe inability to walk can be a red flag pointing away from a purely peripheral issue like neuritis.
Okay, that's a critical distinction. What about other neurological conditions like multiple sclerosis or maybe even tumors?
Yes, those can cause dizziness too, though maybe less commonly as the first symptom. With multiple sclerosis, or MS, which involves damage to the nerve coverings in the brain, and spinal cord vertigo can occur. Sometimes it even mimics vestibular neuritis initially. Overall, about a third of MS patients experience dizziness or vertigo at some point during their illness.
And tumors?
Tumors or malformations in the back part of the brain, the posterior fossa, can also be a cause. A classic example, though uncommon, is a vestibular schwannoma, sometimes called an acoustic neuroma. It's a benign tumor on the hearing and balance nerve. Typically, it causes slow, progressive hearing loss and tinnitus on one side first. Dizziness might come later as the tumor grows and presses on the brainstem or cerebellum.
So hearing loss first is more typical there.
Often, yes. Also, things like Chiari malformation, where brain tissue dips down into the spinal canal, can cause dizziness, sometimes triggered by coughing or straining.
It really seems like so many things can connect back to dizziness. Are there, like, external things? Drugs or chemicals, maybe?
Yes, definitely. That falls under the umbrella of ototoxicity.
Ototoxicity. Ear poisoning.
Literally, yes. Damage to the inner ear caused by certain substances. This can include some antibiotics, especially certain intravenous ones, some chemotherapy drugs, even high doses of certain over-the-counter pain relievers like aspirin or NSAIDs. Environmental chemicals like lead or mercury can also be ototoxic.
Can that damage be reversed?
Sometimes, if the exposure stops early enough, But unfortunately, ototoxic damage can also be permanent, affecting both hearing and balance.
Okay, that's important to know. And one last thing you mentioned, falls. That seems less like a cause and more like a really serious consequence.
It absolutely is, and it's critical we mention it. Falls are a major, potentially devastating complication of untreated or poorly managed balance disorders, especially for older adults. We know, for instance, that untreated BPPV significantly increases fall risk.
And falls can lead to
All sorts of injuries. Head injuries, serious bruises, broken hips, which can be life-altering. It leads to a loss of independence, fear of moving, reduced quality of life. It's why treating the underlying dizziness is so incredibly important, not just for comfort, but for safety.
Wow. Okay, so given this huge range of possibilities, from simple ear crystals to migraines to strokes, how on earth do doctors figure out what's actually causing someone's dizziness? What does that diagnostic process look like?
It's definitely a process
Oh, yeah.
and often a team effort. You might see your primary doctor first, and then maybe an ENT specialist, an otolaryngologist, or a neurologist, sometimes even a physical therapist who specializes in vestibular issues.
Yeah.
It always starts with a really detailed history.
What kind of questions?
When did it start? What does the dizziness feel like? Spinning, lightheaded, unsteady? How long do episodes last? What triggers it? Movement, position, stress, certain foods? Are there other symptoms like hearing loss, tinnitus, headache, numbness? Understanding the exact nature of your symptoms is the biggest clue to whether the problem is likely peripheral in the ear or central in the brain.
Makes sense. History first. Then what?
Then comes a thorough physical exam, including neurological tests, checking eye movements, coordination, reflexes, walking, standing balance. After that, specific tests might be needed.
Right.
Well, hearing tests are crucial if hearing loss or tinnitus is present. Vision tests too, since vision is so linked to balance. Blood tests might be done to look for infection or other systemic issues.
Imaging, like MRIs.
Sometimes, imaging tests like MRI or CT scans are used if there's suspicion of a central cause, like a stroke or tumor, or maybe a structural issue in the inner ear. There are also specialized clinical tests of balance, like posturography, which measures your postural sway on a forced platform under different conditions.
Measuring how steady you are.
Exactly. And then, really key for diagnosing vestibular problems are eye movement tests. These are called electronystegmography, ENG, or videomystigmography, VNG. They record your eye movements while you do specific tasks like following a light or having cool or warm air water put in your ear canal.
Why track eye movements?
Because there's a direct reflex linking your inner ear balance system and your eye muscles, the vestibulo-ocular reflex, or VOR. It's what allows your eyes to stay focused when your head moves. Abnormal eye movements during these tests can precisely pinpoint problems in the inner ear or the pathways connecting to the brain.
Fascinating.
And finally, there's a whole battery of vestibular function tests that specifically assess how well each part of the inner ear, the canal, the otolith organs, is working. It's quite a comprehensive workup.
Okay, so it's a thorough investigation. Once they actually pinpoint the cause, what does treatment look like? It sounds like it has to be personalized.
Oh, absolutely. It's definitely not one size fits all. But the good news is there are many effective strategies. The first step, logically, is to treat any underlying cause if possible. So antibiotics for a bacterial ear infection, for example.
Makes sense. Treat the root problem.
Right. Then lifestyle changes can play a huge role. Conservative things. Like quitting smoking nicotine can really trigger flare-ups for some conditions. Making dietary changes we mentioned, reducing salt for Meniere's disease to manage that fluid buildup. And really learning to identify and manage your personal triggers. Is it stress? Lack of sleep? Certain foods or drinks? Maybe sudden head movements or busy visual environments like supermarkets. Avoiding triggers can make a massive difference.
So self-awareness is key. What about medications?
Medications definitely have their place, but they're used strategically. You might use short-term vestibular suppressant drugs that dampen the inner ear signals, but usually only for acute, severe episodes and briefly.
Because you don't want to stop the brain compensating.
Exactly. Anti-nausea meds, antiemetics can help with sickness. Corticosteroids might be used for inflammation, diuretics for fluid issues like in Meniere's, and for vestibular migraine, specific migraine preventative or abortive meds can be very effective long-term. It really depends on the diagnosis.
And we already talked about those amazing maneuvers for BPPV.
Yes, the canalith repositioning procedures, like the Epley, highly effective for BPPV, guiding those crystals back home. And again, often done right in the office, quick resolution for many.
But the thing that sounds like it has the broadest application, especially for ongoing issues, is vestibular rehabilitation therapy, VRT. Tell us more about that.
Okay, VRT is really where things get interesting for ongoing management. It's a specialized type of physical therapy. Its main goal is to help your brain compensate for the signals it's getting, or not getting, from the damaged or disrupted inner ear system. It essentially retrains the brain.
How is it different from just, say, regular balance exercises?
It's much more specific. VRT directly challenges the key vestibular reflex of the VOR, connecting inner ear and eyes, and the VSR, the vestibulospinal reflex, connecting the inner ear and muscles for posture. It also works on how those reflexes interact with your vision.
So what kind of exercises are involved?
It's tailored to the individual's problems, but often includes specific eye and head movement exercises to improve gaze stability. Balance retraining exercises are huge things like standing on one leg, standing on foam pads, walking with head turns, practicing in environments with less visual input like dim light to force the vestibular system to work harder.
Challenging the system.
Exactly. Plus stretching and strengthening exercises. Often these are things patients can learn and then do regularly at home.
Who benefits most from VRT?
It's really useful for most stable peripheral vestibular disorders, meaning the damage has occurred, but it's not actively fluctuating wildly day to day. So after vestibular neuritis or inactive Meniere's disease is also very helpful for people with chronic motion sensitivity, maybe from migraine, or even after BPPV has been treated, but they still feel a bit off.
And does it work?
The evidence is strong. Studies show VOT significantly reduces the risk of falling, improves overall balance, definitely lessens dizziness symptoms, helps stabilize vision during head movements, and increases body strength and confidence. And starting VRT early seems to help people recover faster and more completely. It's a really powerful tool.
That's incredibly encouraging. What if none of these things work? Is surgery ever on the table?
Surgery is generally seen as a last resort. For severe disabling symptoms that just haven't responded to anything else, medications, maneuvers, VRT, the type of surgery depends entirely on the underlying cause. You might aim to stabilize inner ear function, maybe disable it on one side if it's sending chaotic signals, or remove a growth like an acoustic neuroma.
So reserved for tough cases.
Definitely. It involves risks and careful consideration.
So wrapping things up a bit, what does all this mean for someone actually living with one of these conditions day to day? What are the broader impacts we should be aware of?
Well, beyond the dizziness itself, the impact can be significant. We touched on the risk of injuries from falling, especially in older adults. That's huge. But also, these conditions very commonly contribute to anxiety and depression. Constantly feeling unsteady or fearing the next vertigo attack takes a heavy toll mentally.
I can imagine.
And this combination, the physical symptoms, the risk of falls, the anxiety, can really severely reduce someone's quality of life. Creates a lot of discomfort and limitation. And in some cases, like untreated Meniere's, permanent hearing loss is a potential long-term complication too. So it's definitely more than just feeling dizzy.
Given those potential impacts, what are the most important self-care strategies, and when should someone absolutely push to get checked out?
The big message is, get checked and treated as early as possible. Don't just try to tough it out, especially if symptoms are persistent or severe. Early treatment can prevent long-term damage, like that irreversible hearing loss in some conditions.
Okay, be proactive.
Absolutely. For managing chronic conditions, it's usually a mix of things. Sticking with any prescribed medications. Faithfully doing your vestibular rehabilitation exercises, consistency is key there. Making those lifestyle adjustments we talked about, managing triggers, diet, maybe quitting smoking.
What else?
Always have any necessary medications handy. Know when to take time to rest if symptoms flare up. Avoid activities that feel high risk until you're confident. Reducing caffeine and alcohol can also help, as they are common triggers for many people.
And when is it urgent to seek help?
Well, most people feel lightheaded now and then, but you should definitely contact a healthcare provider if the sensations get worse, happen frequently, or really start impacting your life. Specifically, seek urgent advice if you experience sudden hearing loss in one ear. That needs immediate attention.
Okay, sudden hearing loss is a red flag.
Yes, and also if you've been diagnosed with something and the symptoms aren't improving after a few days as expected, or if they suddenly get much worse, that warrants a call too.
We have really covered a lot of ground today, taking a comprehensive deep dive, uncovering the fascinating science behind dizziness and balance, all the way from those tiny, tiny crystals in the inner ear to complex pathways in the brain.
It's quite amazing how intricate it all is.
Yeah, and I think it's clear that while feeling dizzy sometimes is common, if it's persistent, if it's debilitating, it's really never just normal.
Exactly. There's almost always an underlying cause, and very often something that can be effectively treated or managed. Raises an interesting thought. Our bodies are constantly processing this incredible symphony of sensory information just to keep us upright, balanced,
Yeah.
effortlessly most of the time.
Hmm.
So what happens when we intentionally challenge that system through something targeted like vestibular rehabilitation? It's really a profound reminder, I think, of the brain's amazing plasticity, its incredible capacity to adapt and compensate, even when parts of the system are disrupted. Think about how small, consistent efforts in rehab, those exercises, can lead to really profound changes in how someone functions, their confidence, and ultimately just a huge improvement in their quality of life. It really speaks to the body's resilience.
That's a great way to think about it. So next time you feel a bit off kilter, maybe you'll pause and think about the amazing, intricate workings of your own vestibular system. And hopefully, our conversation today has shed some light on the many ways we can support its health. What stands out to you from our deep dive today? Maybe something that could help someone you know who's navigating this often confusing world of dizziness and imbalance.